Good evening, everybody, and welcome back to another series of the DY Patil lecture series for postgraduate students. We are very happy to have with us Dr. Ravi Gupta, who is a professor at the Department of Psychiatry at AIMS Rishikesh. Dr. Sonal will do the honors of introducing him to all of us. And it also gives me great pleasure to invite Dr. Sonal Shukla amongst us today. She is a senior consultant psychiatrist at Raipur. I've known her for many years and I'm really proud of her achievements. And she's right now at the Manopchar PG Institute of Behavioral and Medical Sciences at Raipur. She is working as a consultant psychiatrist at this institute from 2009 till date. She has 14 years of clinical experience, and she has also been a teacher for MPhil students, for medical social workers, DNB students, as well as being a life fellow of the Indian Psychiatric Society and being a life fellow of the Central Zone, as well as a Geriatric Psychiatric Society. And she's a member of the American Psychiatric Society. She's I've known her for many years from her postgraduate days, so it really gives me pride to invite her. And now she is part of faculty of various sorts. So it's really a very, very heartening moment for me. Welcome, Dr. Sonal, and I hand over the proceedings to you, and I shall come back at the end of the day to give the closing remarks. Over to you. We can't hear you, Sonal. You'll have to unmute yourself. You're on mute.
Yes, okay.
Yeah.
So thank you, sir, for such a great introduction. Thank you so much. I think you are able to hear me now. Hello. Yeah. Are you able to hear me?
Yes, we can hear you now.
Yes. So I would introduce Dr. Ravi Gupta. He's a professor from Department of Psychiatry in AIMS Rishikesh, and his clinical experience is almost 23 years, and he's been given and many awards, some of which are Indian Psychiatry Society for Young Psychiatry Award, Fellowship for World Psychiatric Association, Fellow in Japanese Society of Psychiatry and Neurology, Mini Fellowship, American Academic of Sleep Medicine, and a number of publications are like he has published more than 200 publications. Books written by him is like 19 Indian books and 13 international books. And of course, he has many positions to hold in the organization, such as executive member in Asian and Australia and at large international RLS study group member. He is also guideline committee, and he was also in World Sleep Society as well. So many things to come up with, and his special area of interest is in sleep medicine. So I welcome Dr. Ravi Gupta from Rishikesh.
Uh, Thank you, Sonal, and thank you, Dr. Rashmin, for this opportunity. Uh,
Thank you,
so,
sir.
friends, today we'll be talking about the sleep as well as sleep disorders that we encounter in psychiatry practice. Uh, Largely, this presentation will be focusing on what we are missing and why the psychiatrist should actually invest in the training in the sleep medicine. I do not have any conflict of interest to disclose, and all the people who are joining here, they must know that it is not a complete literature that I could include in this presentation. It is just a kind of a stimulatory lecture to give you an idea about the prevalence of sleep disorders in psychiatry practice as well as psychiatric disorder in sleep practice. We will try to see the cause and effect relationship, whether they occur together as a comorbidity. Uh, what if you treat one, then what happens to the other? Because that again adds to the Hill's criteria for the causation. And then we'll try to understand the pathophysiology of the co-occurrence as well as the causation between both the conditions, the sleep disorders and the psychiatric disorders. Secondly, the disorders that I have included in today's presentation, they are not all sleep disorders. I have focused on mainly the common disorders, for example, the obstructive sleep apnea, insomnia, and restless leg syndrome. And now and then you will find some other sleep disorders. And same with the psychiatric disorder. So if we look at this paper, which was published in 2015, so this was a meta-analysis, and the authors tried to look at the prevalence of the different kind of sleep disorders that we see in different psychiatric disorders. So they mainly focused on the prevalence of obstructive sleep apnea. So here, if you see, you can see that in schizophrenia and other psychotic disorders, nearly 50% of the patients who are coming to our clinic actually do suffer from obstructive sleep apnea. And we have nearly similar data ranging between 30 to 40% from India as well. Similarly, if you look at the prevalence of obstructive sleep apnea and bipolar disorder, so nearly 20% of them in major depressive disorder, nearly half of them in PTSD, again, nearly half of them, they suffer from obstructive sleep apnea. But very unfortunately, we never ever look for the presence of obstructive sleep apnea. We never ever gave even a clinical diagnosis to these patients. Situation when we look at the population-based prevalence, so again here the prevalence is
Sorry.
slightly lesser. Perhaps one reason could be that the patients who are suffering from obstructive sleep apnea, they have multiple other symptoms that we will look later in the presentation, and that forces them to come to the clinics again and again. But even then, if you look at the prevalence in the general population, you will find that the prevalence of obstructive sleep apnea is alarmingly high in the general population who are suffering from different kind of psychiatric disorders as well. So definitely there is a need that we should pay attention to the the obstructive sleep apnea when we are seeing the patient. This was in another meta-analysis which looked at the prevalence of obstructive sleep apnea in depression, bipolar disorder, and schizophrenia. And here you will find that nearly one third of the patients with major depressive disorder, a quarter of patients with bipolar disorder, and nearly one fifth of the patient with the schizophrenia, they suffer from obstructive sleep apnea. If we look at the different kind of psychiatric disorders in the patients who are coming to the sleep clinic and suffering from OSA, you would see that the depressive symptoms can be seen in as high as 35% patients who are coming to us with the complaints of obstructive sleep apnea. Similarly, when we look at the anxiety symptoms, the different studies have shown that nearly one third of the patient with the obstructive sleep apnea, they actually have some kind of anxiety symptoms. So what is the message? That there is an overlap of symptoms between the sleep disorders and the psychiatric disorders. And this is basically when we are talking about uh, this group of patients who are having both the conditions, which is sizable number ranging from one fifth to nearly half, depending upon the psychiatric disorder that we are talking about. So they should be given both the diagnosis. And these patients, they can come either to the sleep disorder clinic for their sleep complaints, and there we have to look for the psychiatric disorders, or they can come to the psychiatry clinics, and there we have to additionally look for the sleep disorders. Now, there are some studies which have looked for the cause and effect relationship. So, if you if we talk about this systematic review and meta-analysis, which focused on insomnia as a predictor of different psychiatric disorders, so you can see here that insomnia actually predicts the incidental depression. Insomnia predicts the incidental anxiety disorders. It predicts the incidental alcohol abuse, psychotic disorder. And friends, we all know that most of the patients of the depression or the anxiety or the psychosis, when they come to us and when we take the history regarding the sleep, it usually antedates that of the psychiatric symptom. Similarly, a number of patients who are suffering from insomnia, they start abusing alcohol as a kind of self-treatment to treat their insomnia, which in a small number of patients gradually progresses to the level of addiction. Now, the same paper, the authors divided the study in the short-term and the long-term follow-up. So short-term follow-up means the studies which have followed up the patient for 1 year only, and long-term are those studies which have followed up the patient for more than 2 years, more than 1 year. So here you can see that the occurrence of insomnia predicts the incidental depression in the short term, but not in the long term. Similarly, you can see here that the occurrence of the insomnia, it predicts the anxiety both in short term as well as long term. Then the authors further did the subgroup analysis for the studies which have included the step diagnosis versus the pure cases of insomnia. So here we can see that even when the initial diagnosis was insomnia as well as some symptoms of depression, even then these symptoms of the depression, they uncovered and they worsened over a period, course of period. But when we look at the pure insomnia studies, that actually predicted the incidental onset of the depression. And same as with the anxiety. So what we can say that the occurrence of the insomnia predicts the future onset of depression and anxiety, both in short term, but the occurrence of the depression in long term is not as strong as it in the short term. When we look at the suicide, a number of studies have shown that the occurrence of the insomnia overall increases the risk of the suicide. When we look at the different diagnostic categories, you will find that this risk of suicide because of the patients who are suffering from sleep disturbances, it is much greater in patients who are suffering from depression. So in depressed patients, we have to pay special attention to the sleep symptoms so that we can prevent the attempted or the completed suicide. Same is with the case of panic disorder. Of course, there was only one study, so we cannot say that the data can be generalizable. Same is with PTSD, schizophrenia, and other psychiatric disorder. So important issue is that the occurrence of the insomnia, which or the other kind of sleep disturbance, if they remain untreated, they increase the risk of suicide in general, as well as when the person is also suffering from other kinds of psychiatric disorder, particularly the depression. And we have a robust data for that. Now, studies have shown that the sleep problems occurring during the childhood as well as adulthood, they increase the risk for the substance abuse. We have already discussed that many of the patients suffering from the sleep problems, the insomnia, or any other sleep disorder, for example, whether we talk about the hypersomnia, whether we talk about the sleep apnea, whether we talk about any kind of parasomnia, to allay their anxiety, to improve their sleep quality, they start consuming some kind of substance abuse as a self-medication, which can, in some cases, who are genetically predisposed and where the environmental factors, they are also conducive to develop the dependence, it develops into the full-fledged dependence. If we look from the cross-sectional studies, nearly 70% of the patients they report some kind of sleep disturbances, either difficulty in falling asleep or maintaining the sleep or early morning awakening or say falling asleep at undesirable times or reduced total sleep time or a poor quality of sleep. And nearly 80% of these patients, they report that the sleep problems they worsened after the use of substance. And nearly 75% of the patients, they use benzodiazepine as a self-medication. But very interestingly, in these cases, though the dose keep on increasing over a period of time, so we can say some of them develop a tolerance, but most of them never use the benzodiazepine for a recreational purpose, which is an important criteria for diagnosing the dependence. And unfortunately, just because of the chronicity of the benzodiazepine use and the dose, which in some cases may be supratherapeutic, we mistakenly diagnose them as having comorbid benzodiazepine dependence. Then, when we talk about the substance abuse, whether the sleep disorder they can give rise to substance abuse, so it has been found that the prolonged sleep onset latency actually increases the risk of the substance abuse. But if the person is having a shorter total sleep time or difficulty in maintenance of the sleep, they usually do not take any kind of addictive substance as a self-medication. So, especially the patients who are reporting for the initial insomnia, they should be considered and that should be treated, addressed because that can give rise to incidental addictive disorder. Uh, if we look at the other meta-analysis, so here the number of studies have shown that the persistent sleep disturbances or shorter sleep duration or long-term sleep duration, they can give rise to the clinical depression or depressive symptom, that is the subthreshold depression. Similarly, short sleep duration in children increases the risk for the ADHD symptoms. And now when we know about the adult ADHD, even in the adults, the short sleep duration because of any reason, whether it is because of the person's own will, they are cutting on their own sleep, or whether it is because of any other sleep disorder, that can actually increase the risk of the inattention as well as impulsivity during the daytime, and they may develop fringe symptoms of ADHD. But these symptoms they actually improve as soon as we treat the sleep disorder. So all the cases of ADHD, whether we are talking about the children or whether we are talking about the adults, they should specifically be asked for the sleep problems. Many of the children they suffer from obstructive sleep apnea or behavioral insomnia of childhood or restless sleep syndrome, so that should be adequately treated. Even after resolution of the sleep, if the symptoms of the ADHD they persist, then only we should give the diagnosis of ADHD. Similarly, the insomnia increases the risk of all psychiatric disorders as well as the anxiety disorders. This has been again shown in another meta-analysis. In when we talk about the Mendelian randomized studies, so ADHD has been linked to the nighttime symptoms of insomnia, the major depression, schizophrenia, and bipolar disorder. They have also been linked with the nighttime symptoms of the insomnia. Depression has been found to be associated with the daytime napping and the hours of sleep, that is the total sleep time. It can increase in depression, as we all know. The device measured sleep time can increase the risk for the bipolar disorder and the schizophrenia, but remember there was no clear evidence for the objectively measured total sleep time on the bipolar disorder as well as schizophrenia. When we look at the sleep disturbance and the bipolar disorder, we all know that the sleep disturbance, the usually harbinger the bipolar episode. Sleep disturbance in the patients with the bipolar disorder usually start during the adolescence, and they usually antedate the acute episode of bipolarity by 1 month to 1 year. Patients who are having bipolar disorder, their children, they usually report sleep problems more frequently compared to the offsprings of the healthy adults. And these children, they have unstable rest activity cycle, and this rest activity cycle can be considered as a symptom of the increased psychomotor activity associated with the manic episode in the animal models. So we can say that the offspring of the bipolar disorder who have unstable rest activity cycle, that means they have multiple interruptions in the sleep, and they have multiple episodes of the sleep. So they are at risk for developing the bipolar disorder. Uh, we all know that the manic episode it is associated with the reduced need for the sleep, and also the insomnia can be seen before as a prodrome of the depressive as well as manic episode. Hypersomnia is usually seen with the bipolar depressive episode only, and occurrence of the hypersomnia differentiates the bipolar depressive episodes from the unipolar depressive episodes with a positive predictive value of around 70%. So that is something that we need to understand, that a person with depression complaining of the hypersomnia always think of bipolar disorder rather than the unipolar depression. Uh, Another paper showed that the bipolar patients, even when they are in remission, they have increased total sleep time along with increase in the wake after sleep onset. So though their bedtime and the wake time is increased, for example, they might be going to bed, waking up at 10 o'clock in the morning, but they are not sleeping for all those 12 hours. They have lot of nocturnal awakenings in between, and that increases the risk for I'm sorry for this technical glitch. So they have it increased, they spend a lot of time awake in these 12 hours. And that is the reason their sleep efficiency is usually reduced. They have a variability in their sleep wake pattern as well as variability in the duration of their sleep. And in the bipolar disorder patient, even after remission, if they report of disturbed sleep, that increases the risk of the suicide. So this is something that we need to address. This study tried to look at the relationship between the sleep and the mental health well-being among the adolescents. So they look at the quantitative aspects of the sleep, qualitative aspects of the sleep, and sleep difficulty, especially the insomnia symptoms. So they look for the internalizing symptoms like depression, anxiety, self-harm, suicide, externalizing symptoms like impulsivity, aggression, agitation, and subjective and psychological well-being. And this study reported that occurrence of the sleep problems at the T1 increases the risk of the internalizing symptom in the future, increases the risk for the externalizing symptom versus the subjective well-being as well as the psychological well-being in future. Similarly, they found that the effect was bidirectional. So occurrence of internalizing symptoms at T1 increases the risk of having this sleep disturbances in future, and same was with the externalizing symptoms and the psychological well-being. So it is we need to understand that perhaps sleep and the psychiatric disorders, they usually increase the risk for one another. So we have seen the data that sleep disorders and the psychiatric disorders, a number of patients they fall in this area, so they have symptoms of both. But also the sleep disorders increase the risk of incidental psychiatric disorders, as well as psychiatric disorders can also increase the risk of sleep disorders in future. Now, what happens when we treat the sleep disorders? So, this was a study where the patients were suffering from depressive disorder along with comorbid insomnia. Unfortunately, we do not frequently diagnose comorbid insomnia along with depression because most of us consider insomnia as a part and parcel of depression itself, so we don't pay attention to it. So, what did the author do? They divided the patients into two groups. This was a randomized control trial. So, one group was given the escitalopram along with the cognitive behavior therapy for insomnia, and other group was given only the escitalopram. So, what did we see that the in the patients who were given cognitive behavior therapy for insomnia, the score on the insomnia severity index they improved with a greater margin compared to those who were not given cognitive behavior therapy for insomnia, and the effect size was large. Similarly, if we look at their total sleep time, total wake time, sleep efficiency, they were also significantly different in both the groups. So you can see here that the sleep efficiency increased from 67% to 84%. But when the CBTI was not given, the difference was just of 4%. And also the quality of the sleep was actually, you can see here, it improved by a large extent compared to the patients who were not given the cognitive behavior therapy for insomnia. So that this study suggests that the patients of the depression who are having the insomnia disorder should be given the diagnosis of comorbid insomnia, and it should be addressed for the betterment of the patients. Now, this was a meta-analysis where which looked at the whether the cognitive behavior therapy for insomnia improved the sleep as well as depression. So here you can see that most of the studies have found that the CBTI not only improved the insomnia that we have seen in the last study, but also improved the response to the extent of the response to the depression. So the patients who are having comorbid insomnia and depression, in those cases, if you treat insomnia, that not only improves the sleep but also the mood. Uh, Further, another meta-analysis showed that the CBTI, when the patients is given to the patients who are having psychiatric disorders along with comorbid insomnia, so it usually prevents the occurrence of incidental depressive symptoms as well as reduces the suicide risk. Now, we already discussed that the number of patients who are suffering from obstructive sleep apnea, they have comorbid depression. So this meta-analysis looked at what happens when we treat these patients, this OSA, with the PEP therapy, continuous positive airway pressure therapy. And you can see here that when we treat the OSA with the PEP therapy, not only the OSA improved, but also the depressive symptom also improved. And this effect is not limited to the CPAP therapy. This effect can also be achieved by the surgical therapy for the OSA, provided the surgical therapy is able to treat the OSA sufficiently. If we look at the relationship between the antidepressants and the sleep, so this meta-analysis looked at the sleep problems to the patients who are given the antidepressants. And you can see here that the amitriptyline actually increases the risk of the hypersomnia, whereas other medications, they actually increase the risk for either the insomnia compared to the placebo. So this is an important thing that we need to remember, that number of patients, they can actually increase the risk of the insomnia as well as hypersomnia. in these patients, and that we all know from the pharmacological point of view. We have already all of us have read the psychopharmacology. So the message is what we can say here now additionally, that if we treat the sleep disorders, that reduces the occurrence of the incidental psychiatric disorder. But if the treatment of the psychiatric disorder can actually worsen some of the sleep disorders, and we all know that the patients who are given the second generation antipsychotics or the first generation antipsychotics, they are at greater risk of having obstructive sleep apnea. They are at greater risk of developing the RLS, which in some cases may be mistaken with the akathisia. The SSRIs and SNRIs, they can cause sleep disturbances, give rise to these pseudo-RBD, pseudo-REM sleep behavior disorder, can give rise to parasomnia, can increase the risk of the obstructive sleep apnea. So these are the things that we need to understand. Now, lastly, we talk about the sleep architecture in psychiatric disorder. So this meta-analysis included 177 studies, and all the studies have found that in the patients with psychiatric disorders, there is a reduction in the sleep efficiency, total sleep time, and proportion of the non-REM sleep. However, REM sleep usually remains unaffected except in patients who are suffering from affective disorder, in which the latency becomes short and the proportion increases. And we all know that short REM onset latency and increased REM density are considered to be an endotypes for the major depressive disorder. If we look at the different kind of sleep disorders, so you can see here that the affective disorders, particularly the major depressive disorder, anxiety disorder, panic disorder, PTSD, eating disorder, autistic spectrum disorder, borderline personality, and schizophrenia, they interfere with the continuity of the sleep. The affective disorder, particularly the depression, anxiety disorder, and borderline personality disorder and schizophrenia, they reduce the depth of the sleep, that is the slow wave sleep. REM pressure increases in the affective disorders as well as the borderline personality disorder, but not the other cases. So psychiatric disorder, they also lead to a change in the sleep architecture, suggesting that they change the neurocircuitry associated with the sleep. If we look at the sleep in the patients who are having high risk for the disorder, as well as those who are suffering from the first episode of the psychosis or the schizophrenia or bipolar disorder, you can see here that the subjective sleep quality actually worsens with the ultra high risk patients for the psychosis, ultra high risk patients for the psychosis as well as bipolar disorder. In all ultra high risk patients, in the first episode schizophrenia, and all ultra high risk and all first episode patients. Similarly, the sleep onset latency is also poor in cases of ultra high risk for psychosis as well as bipolar disorder, first episode patients of psychosis, first episode of schizophrenia, and all first episodes and all the first episodes as well as the ultra high risk patient. So here we can see that sleep and certain characteristics of the sleep probably they tend to work as an endotype associated with certain psychiatric disorders. So perhaps now what we can say we that perhaps the psychiatric disorders and sleep disorder they share some kind of etiological and the pathophysiological links, which increases the chances of their occurrence of together, and also the increase of the chances of one leading to other, and also probably the reason that if we treat one of them, the chances of the other, particularly from the sleep disorder to psychiatric disorder, they improve. This we cannot say for the psychiatric disorders, because the treatment of psychiatric disorder, they actually interfere with the functioning of the underlying neurobiology of the sleep-wake circuitry. So now what is the pathophysiology? One of the reason could be that the sleep disorders they have nighttime symptoms which actually overlap that with that of the psychiatric disorder. For example, the patients might be having sleep disruption in the night, and that sleep disruption in the patients with the OSA or say bruxism or having periodically movement disorder could be associated with microarousal that can lead to occurrence of some kind of behavioral manifestations, whatever they are dreaming at that time. So that can be mistaken for a dissociative disorder. Or these patients sometimes might be having sudden gasping with the breathing. They usually wake up choking, and that can be mistaken for the nocturnal panic attack. Many of these patients, they wake up in the night, they eat a lot of food in the night, and then they go back to sleep. So they are not aware whether they have taken the food at night, and so they become obese, and that can be mistaken for eating disorder. Uh, Interestingly, it's not common, but we got a patient for the RLS, and one of our postgraduate diagnosed that RLS as compulsive leg movement at night. So again, unless you know about these disorders, you tend to make mistake for such kind of diagnosis. Uh, so that could be one thing. Second possibility is that the patients with the sleep disorders, they have a change in the quantity of the sleep, they have a change in the quality of their sleep or the timing of their sleep, or there is a problem with the continuity of their sleep. And these problems can manifest as the irritability or low mood during the day, changes in the cognition, especially the poor attention, concentration, poor decision making, loss of energy, and multiple somatic symptoms like the pain, fatigue. And these daytime symptoms, if we do not talk about the nighttime symptoms, can be mistaken for the ADHD, poor scholastic performance, impulse control disorder, depression, somatic symptom disorder. Many of these patients, they also have low libido, so that can be mistaken for sexual disorder. We have already discussed that these patients, they are prone to develop addiction because when they are not feeling fresh and alert during the day, they consume a very high amount of stimulants during the day, and that precludes them to fall asleep at night. So then they consume probably CNS depressants like alcohol, benzos, maybe opium, and in some cases that can lead to the development of the frank addiction. A number of studies have shown, and there are multiple meta-analyses which show that the sleep disturbances and long waking hours can actually precipitate the psychotic symptoms, especially the perceptual symptoms as well as delusion, especially the persecutory delusions. And they can also lead to cognitive impairment. And we have a number of meta-analyses which show that the insomnia as well as the untreated sleep apnea actually give way for the incidental dementia. Another reason for the co-occurrence or the say cause and effect relationship could be that occurrence of the psychiatric disorders. They actually they occur because of change in the neurotransmitter circuitry. So that actually, I mean, we all know that the neurotransmitter circuitry, which actually regulates the occurrence of the psychiatric disorder, is also overlaps with that of the sleep and wake circuitry. So that can give rise to the changes in the circadian rhythm, changes in the sleep architecture, occurrence of the sleep apnea, or sleep-related movement disorder. There could be genetic vulnerabilities which can be shared between the two. For example, there was a meta-analysis which showed that the long arm of the 5-HTL PPR, it increases the risk not only for the anxiety disorders but also for the insomnia. And we have already discussed that occurrence of the insomnia increases the risk of the incidental anxiety disorders and vice versa. Similarly, the occurrence of the psychiatric disorders can lead to the psychosocial stress, and this stress can change the neurocircuitry, which overlaps that with that of sleep disorders. So it can also lead to the sleep problems. Many of the patients with psychiatric disorders, they have change in their lifestyle. For example, patients might be spending a lot of time in the inactive state that leads to the weight gain, that can also give rise to obstructive sleep apnea. They might be having the altered sleep habits, so that can give rise to circadian rhythm sleep disorder or exogenous clues from the environmental and the work and social events can also lead to the behavioral sleep problems. For example, the fragmentation, disruption in the timing, regularity, and quality of the sleep, as well as hypersomnia. So perhaps this model suggests that both of them they have shared risk factors, and that is the reason the occurrence of the sleep disorders can increase the risk for the occurrence of the psychotic disorder. I'm sorry, can increase the risk for the sleep disorder. When we talk about the sleep and the wake regulation, we all know that wakefulness is promoted by the ascending reticular activating system, which has most of the monoaminergic nuclei like the locus ceruleus, tubulomedullary. These areas are also important for the occurrence of the psychiatric disorder. Similarly, the orexin, which is important for the maintenance of the wakefulness, has been found to be associated with substance use disorder, with number of mood disorders. So, and also the eating disorders. So perhaps that is another reason that the eating disorders, mood disorders, they are seen in patients with the sleep disorders and vice versa. This is an interesting paper which shows that the treatment of the patients with the Q-typing actually increases the collapse of the upper airway. That is why it increases the risk of the obstructive sleep apnea. And they have shown also at the level of the receptors what happens. You can go through this paper. We don't have much time, so we cannot go into the details. So this is another interesting paper, and I think all of you should read it. So this suggests that the mood is also having a circadian regulation, and they have charted the biorhythm of the mood, which suggests that mood is usually best in the morning, and usually it goes to a lower side by the evening. And we all know that the circadian system also regulates the sleep. And we also know that sleep also regulates the mood. So all these three things together, they work in such a way that when there is a circadian misalignment, that actually increases the risk of depression as well as anxiety. Moreover, we have the master circadian clock, which is in the suprachiasmatic nucleus, and we have the peripheral clocks in virtually every organ of the body, including the other areas of the brain. So, what has been seen that in psychiatric disorders, particularly depression and addiction, the peripheral clock in the other areas of the brain, particularly the hippocampus and the reward system, it goes disconnected from the master circadian clock, and that increases the risk of the psychiatric disorder. Similarly, when the peripheral clocks in the liver as well as the gut, they get disconnected from the master circadian clock, so they start running in their own free rhythm. That changes the permeability of the intestine, and that actually leads to the state of inflammation, and that actually alters the gut brain axis through the gut microbiota, and that can lead to the expression of the psychiatric disorders. Similarly, occurrence of depression, it reduces the neuroplasticity, and that can further worsen the sleep as well as depression. And both the conditions, they have the neurotransmitters which are overlapping. So this is an interesting article which you should all read. So, in summary, what we can say that the sleep and the psychiatric disorders they co-occur perhaps because they share the symptoms, perhaps because one of them they increase the risk of the other, as we have seen that treatment of sleep disorders particularly improve the psychiatric disorders. Not so the case from the psychiatric disorders to the sleep disorder, because whenever we treat the psychiatric disorders with the different kind of molecules which act on different kind of neurotransmitters, they actually tend to bring some changes in the sleep. They might be having a common pathophysiological and genetic mechanism. There is a possibility that both of this common mechanism includes the gene, the neurocircuitry, the inflammation, the circadian rhythm, the neuronal changes that occur because of the disease or because of the treatment. And we have also examined that there is a possibility that the nighttime as well as daytime symptoms of the sleep disorders, they can masquerade that of psychiatric disorders. Both the sleep disorders and the psychiatric disorder, they can bring on lifestyle changes that can increase the risk of lead to dietary changes, which can again increase the risk of both the sleep disorders and the psychiatric disorder. With this, I end my presentation here. And if you have any query, I'll be happy to answer that. Thank you very much. Tonal, you are muted.
Unmute. Sorry, sir. Thank you, sir, for your wonderful explanation regarding the sleep disorders and its comorbidities with the psychiatry illness. From my side, one question will be ki what would be your treatment approach in patients who are receiving second generation antipsychotic with the risk of having OSA or RLS? So,
Okay. So when we talk about the sleep apnea, risk of the sleep apnea, it is important that we either change the antipsychotic to one which actually does not cause the weight gain. But weight gain is just one of the mechanisms by which the second generation antipsychotics or the antipsychotics increase the risk of OSA. Another mechanism is that they actually promote the collapse of the upper airway through the serotonergic
mm-hmm.
mechanisms and noradrenergic mechanisms. So it is better to keep the doses as low as possible. And for the RLS, again, I would say that try to keep the doses as low as possible. If the patient get the iron profile done for the patients, especially look for the transferrin saturation. If transferrin saturation is below 45%, supplement the iron to the patient, provided there is no other contraindication for the iron. And that should actually treat the case in most of the cases.
Yes, sir. Thank you, sir. So, if there are any other questions, we would like to welcome the questions to Dr. Gupta, sir.
Okay, so CBTI. Okay, so CBTI is basically behavioral therapy for the insomnia. So this is divided into multiple sessions. So first session is usually dedicated towards providing the basic knowledge about the what unfortunately we call it in psychiatry psychoeducation. So there is a sleep education, I would say it. So this is directed towards providing the information about the sleep hygiene. How does the two process model of the sleep, how does the homeostatic factor as well as the circadian factors they interact, and how the patient they can use both of them to promote their sleep, charting their sleep on insomnia on a sleep diary, and then they come with the sleep diary, and in those cases then we look for the areas where we can intervene. So second session is usually we usually plan for either the stimulus control therapy or the sleep restriction therapy, as the case may be. Then we start working on the cognitive parts associated with the sleep. So that means the pre-sleep cognitions, daytime cognitions after the poor night of the sleep. We try to address them. We try to challenge them as we do with the CBT for depression. And some patients may require additionally the relaxation therapy, the time management therapy. So all these multimodal therapies can be included in the CBTI depending upon different cases.
Sir, one of the most challenging questions which I face in the clinical practice is that the patient usually having some mild depression and anxiety, and he comes to us and he is not having insight into the phenomena. He only requests for us to write some sleep medication like, Madam, please give me Zolfresh. I don't have any depression. So, what should be my approach in such
Right.
patients?
It's really interesting, Sonal. I mean, there is one set of the experts who say that all the patients, even for the acute insomnia, should be given the CBTI only. But I tell you, if you look at the international literature, the adherence to the CBTI is not more than 40%. So a lot
Mhm.
of patients, even in the West, they do
Mhm.
not adhere to the CBTI. And in
Mhm.
India, we have a special problem that the commutation is not, I mean, the patient have to bear the expenses towards the therapy out of their own pocket. Most of the
Mhm.
patients, they are not able to afford multiple visits to the clinic. So this becomes really challenging, and in those cases, you should actually prescribe the hypnotic medication. And I tell you, very unfortunately, we psychiatrists somehow being told that the benzodiazepines they cause dependence. So we don't
Mhm.
even prescribe benzodiazepines to the patients who are actually the good candidates for the
Mhm.
benzodiazepine. Very unfortunately, we say that the patient is not able to discontinue the benzodiazepines after 8 weeks and he becomes dependent. I mean, I have a different opinion. I am having hypertension. If I discontinue my antihypertensive, my blood pressure shoots. Does
Mhm.
that mean I have become dependent on the antihypertensive? No, this does not.
Mhm.
When we talk about the dependence, the very important part that we have forgotten is the intention. Whether the patient is using the medication for the recreational purpose.
Mhm.
If the patient is not using it for the recreational purpose, then probably he's taking this medication for the treatment of the symptoms. And we all know that anxiety and insomnia, they can worsen over time.
Mhm.
So one tend to increase the dose of the medication. If you look at the larger data bank from the UK, I'm forgetting the name of the study that was published in 2019. That was a meta-analysis. So they looked at the data of the 10 lakhs patient, and they found that all of the 10 lakhs patients who have been given benzodiazepines, only 0.01% developed the dependence, meeting all criteria of benzodiazepine dependence.
Mhm.
So that means 99.99% of the patient, 999% of the patient, they never
Yeah.
increase the dose of the benzodiazepines and never ever use for these hypnotics and anti-anxiety medications for the recreational purpose. I am very liberal in prescribing the clonazepam or any other medication for the anxiety, benzodiazepine for the anxiety or the insomnia, as the case may be. And so in insomnia, usually I use the short-acting benzodiazepines, depending upon whether the insomnia is initial or middle or intermediate acting. And I ask many of the patients to discontinue it by themselves. And I get a lot of patients who say that, Doc, I have not taken this medication for past 2 months. But yes, insomnia patients, they continue their medication because insomnia is a chronic problem. It is not an acute problem. We need to understand which problems are chronic, what is their normal trajectory, and based on that, we have to make our decisions. Those who are interested, they can go through one of our papers which we published in Sleep and Biological Rhythms in 2022, and you can have a look and decide yourself whether you should prescribe the benzodiazepines or not.
Someone is asked in the chat that whether daytime nap is good or bad.
Oh, yeah, it's $1 million question, and we don't have any answer for that. There is a data, the literature which suggests that the daytime napping increases the risk for the sleep disorders and the cardiovascular disorders, as well as all causes mortality. That is one thing. But we do not know whether the patients who were included in those meta-analysis, whether they were taking the daytime nap because of the poor nighttime sleep quality. So if a person is having the obstructive sleep apnea or the say narcolepsy, he is taking the daytime nap because of these disorders. Of course, these disorders by themselves increase the risk of all causes mortality as well as the cardiovascular disorder. On the other hand, we need to see that the daytime napping or the biphasic sleep, as we say, because many of us we don't have a consolidated sleep. Many of us, they sleep by 10 o'clock in the night, wake up at 6 o'clock in the morning. So they consolidate their sleep for 8 hours in the night. And they don't sleep, they take any nap throughout the day, their waking period. But some of us, we actually divide our total sleep time, which is very individual, in the night time as well as the daytime sleep. So I sleep for 6 hours in the night, and the remaining 2 hours which I require, I take a nap. So we do not have any data whether this kind of biphasic sleep actually is also associated with the all causes mortality as well as cardiovascular risk, provided you are not having any other sleep disorder that we do not know. So, but in general, most of the data suggests that it is good to have one uninterrupted sleep so that you can function for the remaining period of the wakefulness.
Yes. So I think we have answered all the questions in the chat box as well. Thank you, sir, for your wonderful discussion about sleep. It has cleared a lot of questions and queries. Thank you. Over to Rashmin, sir.
Thank you. Thank you very much, Dr. Gupta. Absolutely brilliant. It's one of the most important conundrums in psychiatry. Despite of all the progress we've made, we still have challenges with regards to handling with this one particular symptom, and we've never been able to come up with a plausible explanation for some of the reasons behind it, as well as the challenges that we face on account of it. So it was a lucid presentation. You touched upon many relevant points, and it was absolutely brilliant. Thank you very much. And I'm sure this video, when it goes live in another couple of day or two, we'll have many more people revisiting this lecture to be able to learn from your discourse today. So thank you once again for making the time and being with us on the Diva Patil Postgraduate Lecture Series. Thank you very much, Dr. Sonal, to take time out of your busy schedule and be with us today.
Thank you, sir.
Thank you all for your active participation. And of course, thank you, Sun Pharma, for your unflinching, continuous support. And we promise to bring you many such lectures going forward as well. So thank you once again, Dr. Gupta, and thank you once again, Dr. Shukla. And we'll see you in the next lecture next month with another exciting topic for you. Thank you very much. Have a great day ahead.
Thank you, and same to you, and happy Holi.
Thank you very much. Thank you all. Thank you.